The Cardinal Rules of Critical Care by Omron MD, Pulmonary and Critical Care Medicine. Critical care medicine can be defined as a fusion of disparate medical specialties refined by applied bedside physiology, whose ultimate goal is to improve overall morbidity and mortality in the acutely ill. It is interdisciplinary, labor-intensive, technically complex, and forms the most expensive part of hospital care. The human body is a wonderfully complex, adaptive, and restorative system. Thoughtful application of these fundamental critical care principles will hopefully recover your patient from the plane of existence, somewhere between life and death, on the edge of chaos. Four cardinal principles define the diagnostic and therapeutic boundaries of the discipline. First, outcome from acute illness is a function of time from diagnosis to initiation of goal-directed therapy, also known as the golden hour. Second, all current therapeutic endeavors attempt to contemporaneously improve oxygen delivery, minimize oxygen consumption, and restore standard state conditions. This early goal-directed paradigm facilitates the patient's unique physiologic reserve and enhances the likelihood of recovery. Oxygen demand is the amount of oxygen needed to satisfy the metabolic requirements of all body tissues. In the resting basal state, 250 milliliters of oxygen per minute is demanded. Oxygen demand is determined by the body mass index, degree of physiologic stress, infection, inflammation, temperature, trauma, surgery, and hemorrhage. It is coupled to cardiac output and minute ventilation, and is most evident during the dynamic phase of shock. Oxygen consumption, in contrast, refers to the total amount of oxygen used by all the different organ systems in the human body. In the resting basal state, 250 milliliters per minute of oxygen is consumed. It equals the difference between oxygen delivered by the arterial system and the amount of oxygen returned to the heart by the venous system. In standard state conditions, oxygen demand is equal to oxygen consumption. This is a cartoon of oxygen demand, consumption, and delivery at standard state conditions. Note that the partial pressure of inspired oxygen at sea level is approximately 160 millimeters of mercury. The partial pressure of oxygen in the alveoli drops to 102 millimeters of mercury once humidified in the alveoli, as calculated by the alveolar air equation. After oxygenation in the lungs with normal venous admixture, the arterial blood has a partial pressure of oxygen of 94 millimeters of mercury and a saturation of 98%, nearly fully saturated. Using the oxygen delivery equation at standard state conditions, 1,000 milliliters of oxygen are delivered to the tissues per minute. 250 milliliters are demanded, 250 milliliters are consumed, leaving 750 milliliters of oxygen remaining in the venous system after extraction from the tissue beds. This is a second cartoon of oxygen demand, consumption, and delivery in clinical shock. Notice that again the arterial partial pressure of oxygen remains unchanged at 94 millimeters of mercury, and the arterial oxygen saturation is nearly fully saturated at 98%. Using the oxygen delivery equation, 1,000 milliliters of oxygen per minute is delivered to the tissue beds. However, 800 milliliters of oxygen per minute are demanded, and only 750 is consumed. Significant demand-consumption delivery disparity is evident. Global tissue hypoxia has begun, and oxygen extraction from the venous bed is nearly exhausted, with a saturated central venous oxygen saturation of 24%. Anaerobic metabolism with lactic acidosis is evolving with ongoing cell death. Shock has been defined as a momentary pause in the act of death. When oxygen demand exceeds consumption, oxygen delivery is compromised. Global tissue hypoxia develops. Anaerobic metabolism screeches to a halt, and anaerobic metabolism with lactic acidosis predominates. If we recall from our biochemistry classes, anaerobic metabolism is a very inefficient engine for ATP production. Cell injury is followed by death. Multi-organ system failure develops, and death soon follows. Notice how often the word death is said in this presentation. This is serious stuff. This description is applicable to all forms of shock: traumatic, septic, obstructive, hemorrhagic, hypovolemic, cardiogenic, neurogenic, and anaphylactic. To sustain aerobic metabolism, cells require a constant supply of oxygen. At the level of the mitochondria, the amount needed seems impossibly small. Under basal conditions, an oxygen partial pressure of 1 millimeter of mercury in the vicinity of the mitochondria meets the organelle's metabolic requirements. This supply is maintained through convective and diffusive transport of oxygen and relies on the property of hemoglobin for oxygen, aka the Oxyhemoglobin disassociation curve. Mitochondrial dysfunction occurs early in both sepsis and shock, and after sustained damage passes a point of no return, at which time cell death is inevitable. To study the causes of cell death, the point at which a cell dies needs to be precisely determined. There is no accepted definition, however, when a cell dies or reaches that point of no return. Ischemic cell death results directly from inhibition of oxidative phosphorylation from lack of oxygen, or anoxia. These changes include decreased pH, metabolic acidosis, decreased ATP synthesis, increased intracellular calcium concentration, sodium-potassium pump failure, with cell membrane depolarization, and once again, the infamous cell death occurs. Respiration is a tidal process. Oxygen demand, delivery, and consumption have to be constantly balanced, and energy is permanently generated in the form of ATP. Tissue hypoxia ensues when this balance is disturbed and oxygen consumption outstrips delivery. Oxidative phosphorylation stalls and anaerobic oxidation occurs. The inefficient anaerobic generation of ATP is quickly exhausted, and this leads to the development of lactic acidosis, a terminal event. This represents, in turn, further worsening of global cellular dysfunction. Tissue hypoxia constitutes one of the most important cofactors in the development of multi-organ system failure. This is well illustrated by the development of hemorrhagic shock. In stage 1 of hemorrhagic shock, up to 15% of total blood volume is lost. This is usually less than 750 milliliters of blood. ATP supply, however, still is equal to ATP demand, and the body compensates primarily by redistribution of blood flow to critical organs. In stage 2 of hemorrhagic shock, from 15 to 30% of total blood volume is lost. This approximates approximately 750 milliliters to 1.5 milliliters of whole blood. ATP supply is still able to meet ATP demand, and the body compensates by recruitment of capillaries to maintain oxygen delivery. In stage 3 of hemorrhagic shock, from 30 to 40% of total blood volume is lost. This approximates 1.5 to 2 liters of blood. In this setting, ATP demand is greater than supply. Anaerobic metabolism with cell injury is developing. Finally, in stage 4, greater than 40% of total blood volume is lost, often greater than 2 liters. ATP demand is much greater than supply. Cell injury with death is inevitable. The first cardinal rule of critical care is time, or the golden hour. Outcome from acute illness is a function of time from diagnosis to the initiation of goal-directed therapy. The more time, the less likely the individual will survive. The importance of time in acute illness was first codified in the American Civil War. Dr. Jonathan Letterman, medical director of the Army in 1862, organized healthcare delivery to improve survival and decrease extraction time from the battlefield arena. During the Battle of Fredericksburg, December 1862, triage was first codified. An ambulance corps was introduced to expedite treatment of traumatic battlefield injuries. Aid stations were positioned close to the battlefield and were integrated with field hospitals to coordinate care and reduce time for definitive treatment. And finally, a civilian nurse corps presence began. I have to interject that any talk that can include a Civil War history lesson with a discussion on shock can't be half bad. This is a picture of Chatham House Field Hospital, Battle of Fredericksburg, Virginia, 1862. The Union Army suffered 12,653 casualties, 1,284 killed, 9,600 wounded, 1,769 captured or missing. This was a tragic Union loss to the South. However, there was a positive side. Charles O'Leary, Medical Director, 6th Corps, Fredericksburg, December 13, 1862, comments, I had the opportunity of putting in operation the field hospital organization and witnessing its beneficial results. Within a few hours after the positions were designated for the field hospitals, the arrangements necessary for the proper care of the wounded were as thorough and complete as I've ever seen in a Civil War hospital. During the engagements of the 13th, the ambulances being guided and governed with perfect control and with a precision rare even in military organizations, the wounded were brought without any delay or confusion to the hospitals of their respective divisions. During World War I, an appreciation of time between traumatic torso wounding and shock treatment was well appreciated. If the patient was treated within 1 hour, mortality was 10%. After 8 hours, the mortality increased to 75%. The major advances in the treatment of penetrating torso injuries from the Civil War to Vietnam can be attributed to the decreased time to treatment for shock. 10 hours, for example, in World War II decreased to 1 hour during the Vietnam War. Vietnam is notable for the introduction of helicopter evacuation, whole blood transfusions, medical teams, and forward hospitals. Notice that a Marine extracted from the battlefield arena within 1 hour of a penetrating torso injury had a survival of 97.5%. That is amazing. Just to clarify the concept, it's not really a golden hour, but a term used to indicate the urgency of care and the crucial importance of time. A quote from the famous trauma surgeon R. Adams Cowley. There is a golden hour between life and death. If you are critically injured, you have less than 60 minutes to survive. You might not die right then. It may be 3 days or 2 weeks later, but something has happened in your body that is irreparable. Dr. Cowley was a surgeon in the Vietnam War, and he applied the military paradigm of expedited extraction and treatment to the civilian sector. He initiated the first EMS system, an air evac system, for trauma in the state of Maryland. This is now the standard of care throughout the entire United States. In 2001, Rivers and colleagues published a landmark article in the New England Journal of Medicine in which aggressive early goal-directed therapy was employed from the outset of recognition of severe sepsis and septic shock, often before admission to the intensive care unit. Early goal-directed therapy was performed during the first 6 golden hours after presentation. Significant reductions in mortality, morbidity in the experimental group that optimized oxygen delivery and consumption variables. Early goal-directed therapy in septic shock set specific goals for the first 6 hours of resuscitation and included the following targets: a mean arterial pressure between 65 to 90 millimeters of mercury, a central venous pressure between 8 to 12 millimeters of mercury, and a central venous oximetry value greater than 70%. The investigators based this approach on the premise that critical underperfusion was poorly recognized in the early hours of sepsis, and that this period of inadequate delivery set the stage for later development of life-threatening organ dysfunction. Trauma surgeons need to be credited for the initial development and application of the early goal-directed therapy paradigm with golden hour concept. Dr. William Schumacher at UCLA published in Chest 1988 a prospective trial of early goal-directed therapy in high-risk surgical patients with shock, trauma, and hemorrhage. Marked improvement in mortality was demonstrated in the experimental groups that received early preoperative and perioperative optimization of oxygen transport variables. The importance of time in the management of sepsis and shock is again demonstrated by the timely administration of antimicrobial therapy. Numerous studies have looked at time to antimicrobial therapy in septic shock, and virtually all have found a reduction in mortality when antimicrobials were given in a timely fashion. Initiation of effective antimicrobial therapy within the first hour after the onset of septic shock-related hypotension was associated with a 79.9% survival to hospital discharge. For every additional hour to effective antimicrobial initiation, in the first 6 hours after the onset of hypotension, survival dropped an average of 7.6% per hour. Amazing. The second cardinal rule of critical care is to maximize oxygen delivery. Global oxygen delivery is the total amount of oxygen delivered to the tissues per minute. Oxygen delivery is enhanced by increasing stroke volume through inotropes like dobutamine, norepinephrine, vasoconstrictors like vasopressin or neosynephrine, and preload augmentation with crystalloid, colloid, or packed red blood cell transfusion. Intubation or non-invasive ventilation will improve global oxygen delivery by its effects on oxygen content and arterial saturation. The oxygen delivery imperative is best conceptualized by review of the Fick oxygen delivery equation. Oxygen delivery in milliliters of oxygen per minute is equal to cardiac output multiplied by the content of oxygen in the arterial bed. This simplifies to heart rate multiplied by stroke volume multiplied by hemoglobin and arterial saturation. Approximately 1,000 milliliters of oxygen per minute are delivered to the tissues and organs under standard state conditions. This cartoon reviews the components of oxygen delivery. Firstly, inspired oxygen at sea level has a partial pressure of 160 millimeters of mercury. In the alveoli, secondary to water vapor pressure and humidification, partial pressure of oxygen is equal to 102 millimeters of mercury. It is then picked up by the arterial system, and once ejected from the left ventricle, the partial pressure of oxygen is 94 millimeters of mercury. This correlates to a maximal arterial saturation of 97%. The concentration of hemoglobin is 15 grams per deciliter, which results in a content of oxygen in the arterial bed of approximately 20 milliliters per 100 cc's of blood. Cardiac output is 5 liters per minute. Through the Fick oxygen delivery equation, approximately 1,000 milliliters of oxygen per minute are delivered to the body tissues and organs. Further review of the components of the Fick oxygen delivery equation. Oxygen content in the arterial blood is equal to the hemoglobin concentration multiplied by the arterial saturation multiplied by 1.34 milliliters of oxygen per gram of hemoglobin, plus the partial pressure of oxygen in the arterial bed multiplied by its solubility coefficient. Notice the preeminent role of hemoglobin in the oxygen content equation and the insignificance of the partial pressure of oxygen. Anemia, needless to say, is highly prevalent in the critically ill, and nearly all ICU patients become anemic after day 3. Optimal management of anemia in the critically ill remains controversial to some. I will come back to this question later in the talk. One point needs to be made very clear. Anemia in the critically ill with an oxygen demand delivery consumption disparity is a predictor of death and adverse outcomes. Hemoglobin actively regulates oxygen transport through the oxyhemoglobin disassociation curve. The oxyhemoglobin curve is S-shaped, meaning that it is more steep at lower partial pressures of oxygen and nearly flat when the partial pressure of oxygen is greater than 70 millimeters of mercury. As blood moves from the arteries to the capillaries, it is exposed to a lower partial pressure of oxygen in the arterial bed, and more oxygen is released. Changes in body temperature, increases in the hydrogen ion concentration, or the partial pressure of carbon dioxide, moves the curve to the right and reduces the oxygen binding affinity of hemoglobin, which facilitates its release into the tissues. This is known as the Bohr effect. Cardiac output has the greatest overall effect on the oxygen delivery equation. It is equal to heart rate multiplied by stroke volume. Notice that the stroke volume is the most frequently manipulated variable in the equation. Heart rate is usually auto-regulated and not manipulated. The components of stroke volume for review are preload or preload augmentation, afterload, and contractility. This table demonstrates the changes in oxygen delivery from standard state conditions in the setting of oxygen desaturation, anemia, and low cardiac output. Case example number 1 is a normal subject with normal oxygen delivery. The fraction of inspired oxygen is 21%. The partial pressure of oxygen in the arterial bed is 70 millimeters of mercury. This correlates to a saturation of 96%. Hemoglobin is 13 grams per deciliter. Cardiac output is 6 liters per minute. This equals to an oxygen delivery of 1,000 milliliters per minute. Case example number 2 is a patient that presents with hypoxia, anemia, and reduced cardiac output. The fraction of inspired oxygen remains 21%. However, the partial pressure of oxygen in the arterial blood is reduced to 45 millimeters of mercury. The arterial saturation is reduced to 75%. The hemoglobin is reduced to 7 grams per deciliter, and the cardiac output is reduced to 4 liters per minute. This is an overall oxygen delivery of 288 milliliters per minute, or a 71% overall reduction from standard state conditions. Case example number 3 is similar to case example number 2, except now we increase inspired FiO2 to 60%, increasing arterial saturation to 98%. This results in an overall improvement in oxygen delivery of 384 milliliters per minute and a 25% improvement from baseline. Case example number 4 is similar to case number 3, except now we further increase hemoglobin from 7 to 10.5 grams per deciliter. This results in an increase in oxygen delivery to 568 milliliters per minute, or an overall 48% improvement from baseline. Transfusion above 10 grams per deciliter is strongly discouraged in clinical medicine, secondary to increases in blood viscosity and, as well, myocardial oxygen consumption. Case example number 5 is similar to case number 4, except now we increase cardiac output from 4 liters per minute to 6 liters per minute, with an overall 50% improvement in oxygen delivery from baseline to 852 milliliters per minute. The overall point being this: increasing cardiac output has the greatest overall effect on oxygen delivery. The components of oxygen delivery in review. Oxygen delivery is equal to the partial pressure of oxygen multiplied by its solubility coefficient plus hemoglobin multiplied by arterial saturation. The entire expression is then multiplied by cardiac output. Increasing cardiac output has the greatest effect on oxygen delivery because of the multiplier effect. It multiplies against hemoglobin, arterial saturation, and partial pressure of oxygen in the arterial blood multiplied by its solubility coefficient. Increasing hemoglobin is also good, but it has less of a multiplier effect. Partial pressure of oxygen in the arterial blood has a small, negligible effect on overall oxygen delivery. Another component of the Fick oxygen delivery equation that merits individual review is stroke volume. Preload augmentation, or stroke volume, directly increases oxygen delivery. The relationship between left ventricular end diastolic volume, or preload, and force of contraction, stroke volume, was described by Otto Frank and Ernest Starling at the turn of the century. Simply stated, an increase in left ventricular end diastolic volume, or preload, will normally result in an increase in stroke volume. The Frank-Starling curve has two notable regions, a preload-dependent and a preload-independent region. The preload-dependent region is volume responsive, and the preload-independent region is volume unresponsive. It is critical to know where the patient is on the Frank-Starling curve before you start preload augmentation or volume loading to enhance cardiac output. If you are wrong, you will drive the patient into hydrostatic pulmonary edema without any improvement in cardiac output. Notice in cardiogenic or septic shock, the contractile performance of the heart is greatly reduced, diagrammatically represented by the right and downward shifted Frank-Starling curve. After a crystalloid bolus of 1 liter, end diastolic volume may be increased by 50 milliliters, resulting in a more forceful systolic contraction and greater stroke volume ejected from the left heart. If left ventricular end diastolic volume is too high, the force of the contractile relationship of the left heart myocardium is greatly reduced. No significant improvement in stroke volume or cardiac output is realized. Continued fluid loading in this circumstance will result in hydrostatic pulmonary edema. For any heart, there are a series of Frank-Starling curves depending on clinical status. As contractile function worsens in the failing heart, the preload-independent region increases and the preload-dependent region decreases. This places the individual at higher risk of hydrostatic pulmonary edema in inappropriate fluid loading. How does an intensivist know where the patient is on the Frank-Starling curve to maximize cardiac function and improve oxygen delivery? The answer is applied bedside physiology. The leg raise maneuver, pulse pressure variation, the veno-arterial partial pressure of carbon dioxide difference, continuous cardiac index monitoring, mixed or central venous oximetry, lactate and or metabolic acidosis assessment, and finally, real-time bedside echocardiography. A special commentary on myocardial oxygen delivery. Coronary blood flow is greatest during diastole and least during systole, and coronary perfusion pressure is calculated as aortic diastolic pressure minus left ventricular end diastolic pressure, or pulmonary capillary wedge pressure. Normally, this is equal to 68 millimeters of mercury under standard state conditions. In cardiocerebral resuscitation for cardiopulmonary arrest, our primary goal is to increase aortic diastolic pressure. Survival and outcome from cardiopulmonary arrest is directly related to a higher coronary perfusion pressure from continuous chest compression, CPR. The oxygen consumption imperative is best conceptualized by a review of the Fick oxygen uptake equation. Global oxygen consumption, VO2, represents the total amount of oxygen consumed by the tissues per minute. VO2 is equal to the arterial oxygen delivery minus the venous oxygen delivery. The difference represents the oxygen consumed by the tissues. Normal oxygen extraction is 250 milliliters per minute. The third cardinal rule of critical care is to minimize oxygen consumption. Judicious use of sedation, analgesia, anti-inflammatory drugs, and infrequently neuromuscular blockade minimizes fever, agitation, anxiety, pain, and work of breathing. Induced hypothermia globally decreases oxygen consumption. Therapeutic adjuncts include invasive and non-invasive ventilatory support, bronchodilators, diuresis, pulmonary toilet with a decrease in overall work of breathing. Antibiotics alter the inflammatory cascade indirectly and have indirect effects on oxygen delivery and consumption. Myocardial consumption in congestive heart failure is a special case example. Beta blockade for heart rate controlled In the acute setting, morphine sulfate for preload and afterload reduction. Angiotensin 1 and 2 receptor blockade for preload and afterload chronic reduction. Digoxin for contractility, and neuroendocrine treatments to improve the Frank-Starling relationship by diuresis, aldosterone antagonists. Initiation of CPAP acutely or chronically to decrease overall work of breathing and as well for afterload reduction. The Fick equation for oxygen consumption is equal to the cardiac output multiplied by the arteriovenous oxygen content difference. The arteriovenous oxygen content difference can be replaced by the arteriovenous oxygen saturation difference. This is critical because the arteriovenous oxygen saturation difference, also known as the oxygen extraction ratio, is a global measure of the adequacy of both oxygen delivery and consumption. Clinically, simultaneous arterial and venous blood gas analysis can provide quick information at the bedside on the initial oxygen delivery and consumption state in a critically ill patient. And serial measurements assess the adequacy of those interventions to improve those parameters. An arterial blood gas assesses oxygenation through the alveolar gas equation, ventilation by direct measurement of carbon dioxide, and arterial acid-base status, manifested by pH, PCO2, bicarbonate, and standard base excess. The simultaneous central or mixed venous blood gas augments this information by providing the arteriovenous oxygen saturation difference, or extraction ratio, the veno-arterial CO2 difference, which provides information on cardiac index, and an estimate of intrapulmonary shunt fraction. These concepts are reviewed in the discussion Arterial Blood Gas Analysis in Critical Care in the same YouTube series. So, what if we solve the Fick oxygen consumption equation for mixed venous oxygen saturation? The oxygen consumption imperative is best conceptualized by a review of the Fick oxygen uptake equation solved for mixed or central venous oxygen saturation. To improve SVO2, only 4 physiologic parameters can be manipulated: the arterial oxygen saturation, oxygen consumption VO2, cardiac output, as manifested by stroke volume and heart rate, and finally, hemoglobin concentration. SVO2 is directly proportional to whole body oxygen consumption and inversely proportional to cardiac output, making it an ideal parameter for monitoring the ratio of oxygen supply to demand. This cartoon represents the arterial and venous oxygen saturation in various organ beds in the human body. Different organ systems display a heterogeneous oxygen extraction level, representing their differences in metabolic activity. The spectrum of venous saturation figures for different organs is already quite disparate under physiologic conditions. The heart, for example, has the highest extraction, SVO2 equal to 37%. The skin has the lowest extraction of oxygen, SVO2 equal to 88%. The SCVO2 or SVO2 saturation, remember, is a flow-weighted average of the venous saturations from all the perfused vascular beds in the right atrium or right ventricle outflow tract. Once again, there are 4 determinants of SVO2 or SCVO2 in the human body: arterial saturation, oxygen consumption, cardiac output, and hemoglobin. And finally, SVO2 represents the physiologic oxygen reserve in times of stress. This table reviews the limits of mixed venous oxygen saturation in critical illness. The human body has no storage system for oxygen. When delivery of oxygen is impaired, the body defends against hypoxia by increasing oxygen extraction from the venous bed. An SVO2 greater than 75% represents normal extraction. The supply of oxygen is much greater than the demand. When SVO2 is greater than 50% but less than 75%, we see compensatory extraction, increasing oxygen demand or decreasing oxygen supply. When SVO2 is greater than 30% but less than 50%, we see the exhaustion of extraction and the beginning of lactic acidosis. The oxygen supply is less than demand. When SvO2 is less than 25%, the limit of extraction, the process of cell death begins. This physiological fact renders SvO2 measurement a key physiologic parameter in critical illness. Serial measurement of the arteriovenous oxygen saturation is a highly effective clinical tool for monitoring the cardiorespiratory system. Why measure central or mixed venous oxygen saturation in critical illness? Well, first of all, a decrease in SvO2 is an early indicator of a threat to tissue oxygenation. It provides earlier information to allow for diagnosis and treatment interventions. Again, the normal range is between 60 to 80%. It forms a critical component of the early goal-directed therapy algorithm. Recognition of global oxygen demand, delivery, consumption disparity is very difficult early in shock without microcirculatory markers such as SvO2 or lactate and metabolic acidosis. SvO2 is your oxygen reserve in times of stress, and when exhausted, you die. This graph demonstrates in real time the value of serial or continuous monitoring of arterial and venous oxygen level during cardiogenic shock. The bottom graph represents a laboratory-induced cardiac shock in an animal model system. Notice serial assessment of the partial pressure of oxygen in the arterial bed during cardiogenic shock has no clinical value, just background scatter. Serial assessment of the partial pressure of oxygen in the venous bed, or the mixed or central venous oxygen saturation, tracks in real time the failure of oxygen delivery and normalization when cardiac function is restored. The ScVO2 equation represents one of the master equations in intensive care medicine. In acute illness or post-op surgery, arterial saturation, oxygen consumption, cardiac output, and hemoglobin are dynamically changing concurrently. They represent the only four parameters that can be manipulated by the clinician to improve ScVO2. Optimize each parameter and then recheck the ScVO2 to assess response to intervention. Transfusion is critical in early goal-directed therapy to increase oxygen delivery and secondarily to increase mixed or central venous oxygen saturation. Transfusion of packed red blood cells in critically ill patients improves oxygen delivery by increasing stroke volume and oxygen carrying capacity simultaneously. This intervention should only be done when the microcirculatory markers demonstrate oxygen delivery consumption disparity. When no disparity exists and oxygen delivery equals consumption, transfusion of blood products results in no meaningful improvement in ScVO2 or oxygen delivery. Further, this intervention puts the patient at risk for the triple threat: TRALI, transfusion-related acute lung injury; TACO, transfusion-associated circulatory overload; and TRIM, transfusion-associated immunomodulation with a higher risk of infection. I strongly recommend using ScVO2, lactate, and metabolic acidoses as your primary transfusion triggers, and when normal, do not transfuse. Pack red blood cells. The final cardinal rule of critical care is to restore standard state conditions, or the endpoints of resuscitation. What are standard state conditions? The Surviving Sepsis campaign targets central venous pressure, 8 to 12 millimeters of mercury, a mean arterial pressure greater than 60 millimeters of mercury, and a central venous oxygen saturation greater than 70%, because its focus initially is on emergency room resuscitation. In the intensive care unit, we go and should go further. We attempt to normalize oxygen delivery with consumption. Normothermia, not hypo or hyperthermia. We restore intrinsic vascular tone and liberate the patient from pressors. We initiate enteral feeding. We restore metabolic acid base status, pH 7.4, PCO2 40, and standard base excess equal to 0 through physical chemical resuscitation and strong ion difference. We restore volume status to premorbid levels by a fluid restrictive strategy and diuresis. Finally, spontaneous awakening and breathing trials, and ultimately liberation from mechanical ventilation in acute respiratory failure. Conventional endpoints are lagging indicators of inadequate oxygen delivery and consumption. Blood pressure, heart rate, urine output, mental status changes, and central venous pressure, which is a poor surrogate of filling pressures. Resuscitation to these conventional endpoints is problematic. 50% of critically ill patients who present in shock who were resuscitated to normal vital signs continued to have increased lactate and low SVO2, SCVO2, or inadequate oxygen demand delivery. How do we know that oxygen consumption and demand are optimized? More effective resuscitation endpoints are continuous cardiac index, monitoring for pulse pressure variation or systolic pressure variation, mixed or central venous oxygen saturation, serum lactate as an indicator of tissue hypoxia, the veno-arterial PCO2 difference, which directly correlates with cardiac index, metabolic acid base status as an indicator of cellular death and or perfusion failure. But the most effective resuscitation endpoint is real-time cardiac ultrasound. This is an example of an arterial pressure waveform. And what we see is systolic pressure variation, the difference between the maximal and minimal values of systolic blood pressure during pulse pressure variation, this cyclic change in the arterial pressure waveform over time. A systolic pressure variation greater than 15 millimeters of mercury in the positive or negative direction is highly predictive of hypovolemia and preload dependency. Some commentary on resuscitation endpoints. A single set of data points is useless in the intensive care. Construct multiple data points to assess trends and response to treatment interventions. Also, base bedside interventions on objective clinical data. Finally, resuscitate each organ system. Central nervous system, for example, maximize cerebral perfusion pressure and recognize and treat delirium early. Lungs, mechanical ventilatory support to minimize barotrauma, volutrauma. Cardiac, preload augment and afterload reduce to optimize contractility and cardiac function. GI tract, initiate enteral nutrition early and as well provide good oral hygiene. And skin, initiate measures to prevent skin breakdown with frequent skin checks. Real-time critical care ultrasound is the most important innovation for both diagnosis and therapy in the past decade. It allows real-time assessment of cardiac function and the adequacy of cardiac filling pressures during the initial and maintenance phase of resuscitation from shock. Direct visualization of right ventricular pressure overload from pulmonary embolism, or immediate recognition of cardiac tamponade or pulmonary pneumothorax. It allows bedside screening for deep venous thrombosis, assessment of the pleural and peritoneal space for fluid accumulation, just to name a few. The bedside ultrasound has become the most important diagnostic instrument in the intensive care unit. I end the talk with my first slide to comment. Reduction of critical care medicine to only 4 rules is quite a Herculean task, but with simplification comes elegance, beauty, and far greater understanding. I thank you for your time.